Hot off the presses. I believe this is episode number 5050. Oh, I'm halfway to the century mark. I love it. We're growing. We're going to keep this thing going. So today's title is Testosterone Cancer Risk in the Changing Medical Narrative. I found some articles that have just been published. Some of them are not even at full release yet. I found this information to be very interesting. So most times when we talk about testosterone and cancer, we're always considering prostate cancer. I will talk a little bit about prostate cancer as well, but this is pretty interesting information that I have found through the most recent data. So today we're going to cover two major developments that are reshaping how we think about testosterone. First is the new data linking low testosterone to increased cancer risk. And second, a proposed FDA shift in how testosterone therapy is labeled and prescribed. So, put together, these represent a meaningful shift in the broader medical narrative and one that every man should understand. Low testosterone and cancer risk. Let's start with the research. A large study published in The Lancet, Healthy Longevity, looked at over 26,000 men across multiple countries and followed them over time. That's a pretty large study. What they found was significant. Men with very low testosterone levels had about an 18% higher risk of dying from cancer later in life. And even more clinically useful, a threshold emerged. When testosterone levels dropped below 8.6 nanomoles per liter, or roughly 250 nanograms per deciliter, that is the low end of the normal range for us here in America, cancer risks began to increase. Now, this is a critical point. This doesn't prove that low testosterone causes cancer. And just notice this observation. It strongly suggests that low testosterone is a biomarker of poor overall health and potentially worse outcomes if cancer does develop. The cancer prostate myth, I think it's worth mentioning again. For decades, one of the biggest concerns around testosterone had been prostate cancer. When I first started in this practice in 2006, and many detractors in medicine informing me that if I was to embark on giving men testosterone, then I was increasing their risk of prostate cancer. And it never made sense to me, and this contradicted the information that was available and the dogma of urology of the day. But it just didn't make sense to me. And I had gone to some meetings with different organizations, and there was a lot of data to suggest the opposite. It didn't make sense. And with time, in about 5 years of me doing this, it came out that the studies proved that the administration of testosterone did not increase the risk of prostate cancer. So this study adds to a growing body of evidence that I just referred to. There was no link between natural testosterone levels and prostate cancer risk. And now there's plenty of data showing that giving testosterone does not increase the risk of prostate cancer. Instead, prostate cancer was associated with low sex hormone binding globulin and low luteinizing hormone. So that's important because that's a big shift, and it challenges a long-standing fear that higher testosterone levels inherently increase prostate cancer risk. This is also important because there are a lot of people out there going, how do I lower my sex hormone binding globulin so I want more free testosterone? And that's not, I think that's the wrong way to look at it. It is a way to improve your free testosterone, but I think a better way is to support the testosterone with the precursors of testosterone that get diminished when you administer testosterone and you don't backfeed with these precursor hormones such as DHEA and pregnenolone. And the data is pretty clear on that. The FDA is changing its position. Now let's connect this to the second major development. The FDA is proposing updates for how testosterone therapy is labeled, and these changes are significant. Here are 3 key shifts. First, the FDA is considering removing prior restrictions on age-related low testosterone. for the longest time, and currently, the FDA's position was unless you have documented low testosterone, and that is determined by 2 lab tests that were drawn before 9 o'clock in the morning on 2 separate days and both levels being below 300. If you meet that criteria, then and only then can you consider the symptomology that the patient is suffering with. If they have one level that's 301, then you have to tell them, well, you have normal testosterone and there's nothing I can do for you. This is just age related decline in testosterone. It's normal. Learn to suffer with it. Welcome to the golden years. And I always thought that that was quite frankly BS. Um, and most practitioners in this space feel the same way. Now, there are a lot of physicians out there that practice insurance based medicine. Frankly, the vast majority do. And they are beholden to the insurance companies and the guidelines because they cannot get paid if they do not follow those guidelines. So even if they really wanted to treat the patient, they can't. The insurance won't cover the medication, the insurance won't pay the provider, and that's that. And it's, in my opinion, that is a terrible way to do medicine. This is a classic case of the tail wagging the dog. Freaking insurance companies should stay in their damn lane and let the healthcare providers decide what is best for the patient and then compensate for that. That's not how the system works. I digress. Back in 2015, labeling suggested that testosterone therapy hadn't been proven safe, or effective for age-related decline. Let me say that again. Back in 2015, labeling suggested that testosterone therapy had not been proven safe or effective for age-related decline. Newer evidence, including the Traverse trial, which followed over 5,000 men, showed no meaningful increase in heart attack or stroke risk. Regulators are now acknowledging that the previous caution may no longer be justified. Second, the FDA is proposing to relax warnings around prostate cancer. Previously, testosterone therapy was broadly discouraged in men with known or suspected prostate cancer. Under the new proposal, it would be restricted mainly to men with metastatic disease, while allowing more flexibility in others with appropriate screening and monitoring. So, with metastatic disease, that's a different ballgame. But with prostate cancer in situ, staying within the prostate and it's not growing, it's being monitored. There are a lot of physicians, both in the urology world, in the andrology world, and quite frankly, with my level of training, I'm very comfortable treating men with prostate cancer with testosterone, with active surveillance. This is now becoming a new standard of care. Again, this aligns with what we're seeing in the research. Testosterone itself does not appear to be the driver of prostate cancer risk. Third, the FDA wants to update warnings around prostate enlargement or BPH. Current labeling suggests testosterone may worsen symptoms, but newer data doesn't support this in men with mild to moderate disease. So instead of a blanket warning, the emphasis is shifting towards individualized monitoring. What this means clinically, when you put these two developments together, a much clearer picture emerges. We're moving away from a simplistic view of testosterone as dangerous and toward a more nuanced understanding. Low testosterone is often a signal of underlying metabolic dysfunction. Normal physiologic testosterone does not appear to increase prostate cancer risk, nor does giving testosterone therapy increase the risk. Testosterone therapy, when properly selected and monitored, appears safer than previously thought. That said, this is crucial. The evidence does not show that giving testosterone prevents cancer. So, men with low cancer or low testosterone are at a greater risk for developing cancer by 18%. I can't say at this juncture that by giving testosterone to improve their testosterone, that it reduces that risk. But theoretically, that makes sense because if you improve their testosterone and their metabolic parameters improve around it, then one would think that there would be a lower risk of cancer. That is pure speculation, though. So this is not about prescribing testosterone indiscriminately. It's about recognizing that if someone has low testosterone and it's a clinical opportunity to intervene more broadly. Here's how I would distill this in a real world guidance. If your testosterone is low, do not ignore it and do not oversimplify it. It may reflect poor metabolic health, increased inflammation, lifestyle factors like sleep, diet, and activity levels may be poor and can be monitored and can be changed to improve your natural testosterone level, or other underlying medical conditions may be at play. In some cases, appropriately managed testosterone therapy may be part of a broader optimization strategy, but it should never be the only intervention. I've said this is why I've gotten away from the testosterone only treatment model. There are many clinics out there that are doing this model, and frankly, it is not good medicine, in my opinion, for the vast majority of men that are going to these clinics. They do a paltry job of looking at the underlying health and looking at labs, a full assessment. Their model is based off of money. It is a cookbook approach. Everyone goes in, everyone gets their testosterone, everyone gets something to block the conversion of testosterone to estrogen. Everyone, or most everyone, gets some HCG. It is a money-based system, unfortunately. There is no nuance. It's very cookbook. If it's just not a good way of doing medicine. I had done that in the past in my practice because I had seen how bad these other places were doing things, and I wanted to give patients an opportunity to have testosterone therapy done appropriately. So I did a very narrow testosterone only program. And the goal in that program was to ensure that the men that came into that had a good primary care physician, that they were getting labs at least drawn annually, and they were taking care of any metabolic issues or other underlying health conditions. But I found that more and more men were coming to me and only wanting this specific therapy. And so, and they weren't following through with an annual physical with their primary care provider, or other things I thought were necessary. So I personally removed that from our practice. The people that had it, I left them grandfathered in, but I am trying to get them more onto other more comprehensive medical programs so we can do a much better job of men's health. We also do women's health here, but this conversation is really focused on men's health. So bottom line is this: low testosterone is not just about symptoms. It may be an early warning signal for deeper health issues, including increased long-term cancer risk. At the same time, the fear surrounding testosterone therapy is evolving based on newer and better data. As always, the goal isn't just to treat a number, it's to optimize health, longevity, and overall physiology. Can't tell you how many times I've had men come in and ask, well, I'm X amount of years old. What should my testosterone level be? And I tell them, I don't know. It is nuanced. It depends. Some men may feel great at any age with a level of 500. I have many patients coming in with levels of 500 and as symptomatic as one would think they would be if their level was 200. So in those individuals, a lot of times the problem is the free testosterone is too low. We improve the free testosterone, and lo and behold, their symptoms get better. So to ascribe a total testosterone number to an individual based off of age or any other factor, to me indicates, especially if it's a healthcare provider, that they have no idea what they're doing, number one, and they should refer out to somebody who does and not undertake just blindly giving a therapy to someone. Now, I just showed you that I don't believe that testosterone therapy is dangerous, but you still want to do it under guidance of somebody who is well versed in it and does it as safely as possible. What we're trying to find is the lowest effective dose. not the lowest dose that where the insurance company is going to reimburse you. The testosterone level was 250 and you improved it to 500, but the patient doesn't feel any better. That is a failure. However, in those situations, those doctors are afraid to improve the level of therapy because, well, they're within the normal range and I can get my payment from the insurance company. I don't think that's good medicine. But what do I know? I'm just a humble, simple former ER doc now running a very successful integrative wellness clinic and been doing this for 20 years. So, if you are a male and you are interested in improving your testosterone level or at least investigating it to see why you might not be performing the way that you expect to be performing, given your level of activity, your diet, your exercise, your previous levels of activity, come see us here at Ageless Forever. 6020 South Rainbow Boulevard here in Las Vegas. Give us a call, 702-838-1994, or see us on our website at www.agelessforever.net. We'll be happy to sit down with you and show you what programs we have to offer to optimize your health span, and improve your longevity. I always leave with this. I tell my patients, nobody can tell you they can promise you a second more on this earth because none of us have an expiration date written on us. We don't know when our time is going to be. It could be done in a minute for me. You guys could watch me die right here on camera somehow, right? I thank God that that's not going to happen, and I pray that that doesn't happen. My point being, we don't know how long we're going to be here, but let's be as healthy as we can while we're here so we can do all the things that are on our bucket list and all the things that we enjoy doing, enjoy our families to the fullest extent, and not be stuck coming home from work, sitting on the couch and falling asleep. So, thank you for your time, and we look forward to seeing you here soon and next for our next episode.